I'm presenting today on headache to be moderated by Dr. Gerald. Okay, thank you very much. Thank you, Dr. Gerald, for the opportunity to moderate. I also want to thank the department. We have two of our senior colleagues here, Dr. Nge and then also Dr. Makinde. So I want to thank them for coming. Today we'll give a short presentation on headache. It's a very voluminous topic and very large, but I tried as much as possible to just streamline it to what we usually see as doctors, as medical officers in the outpatient department. My name is Dr. Glorieme, and I'm presenting from Kelina. I'll do it very quick, no problem. I have about 15 minutes to present, so I'll be quite fast. So this is just an introduction. I'll give a brief epidemiology, I'll give a brief classification, etiology, some investigations, and treatments. So as per introduction, what is headache? 4% have daily or near daily headache. Globally, it's been estimated that the prevalence of headache disorders among adults, symptomatic at least within 1 year, is about 50%. Most of it is within the active labor force age, so within the age of 18 to 65%, and then about 15% would have reported migraine within the year. It has a female preponderance, so it affects females more than males, most likely due to the hormone. And then it can be defined as either chronic or episodic. The American Headache Society estimates that about 37 million people living with migraine and other headache syndromes live in the US currently. There was a study done at LaSutte to determine the prevalence of primary headache disorders in the teaching hospital. They had about 402 subjects, and of the 402, 234 were females. Like I said earlier, it affects females more than males, and about 168 were males. So about 54.4% of all patients with headache were females. And of all of them, the most common type was what we call tension type headache. So headache can be classified into two types, primary and secondary. For the primary headache, it can be defined as one which does not necessarily have any underlying cause, disease, trauma, or medical condition. Most times, people with primary headache, physical examination and lab studies are generally normal. And it's the commonest type of headache, or the most common type of headache we would see in the OPD. Like I said, it could be divided into episodic and chronic headache. And then some examples are tension type headache, cluster headache, and then the migraine headache. The episodic headaches are more common. I will define headache as being chronic when it occurs for more than 15 days in a month, lasting more than 6 months. As for the secondary headache, there is usually an underlying disease or condition which can be linked to the headache. It could be intracranial, extracranial, or due to metabolic diseases. For intracranial causes, you can have subarachnoid hemorrhage, you can have meningitis, you can have abscesses. For the extracranial causes, you can have sinusitis, otitis media, glaucoma. Metabolic disorders, you can have carbon monoxide poisoning. So it's just the same thing I've said, but a more detailed example of causes of primary headache, or secondary headache rather. Now, for the purpose of this discussion, we will dwell more on primary headache, because that's what we would usually see, and that's the most common type. Now, of primary headache, we'll start with tension headache, which is the most common type of primary headache. And I said it could be episodic or chronic. I think I've tried to just explain what chronic headache is, lasting for more than 15 days in a month and for more than 6 months. And it's usually due to a disorder of CNS pain modulation. It has no gender predilection, so it affects males and females just as much. And it's usually caused or precipitated by stress, the exam stress, work stress, also be due to hunger, insomnia, eye strain, or poor posture. It's usually of gradual onset, and notice that it starts from the occipital region and then radiates to the frontal region. It's usually bilateral, and it feels tight. I had this band-like pain sensation. So the patient will tell you that it feels like something is squeezing, like there's a tight band squeezing on the head. And the pain is usually less in the morning, and it increases as the day goes on. And most times there's no accompanying nausea, vomiting, there's really no photophobia or phonophobia. And most patients are able to carry on their normal work. So this is just a diagram trying to represent what tension type headache feels like. Now, how would we diagnose someone of having tension type headache? Generally, the headache lasts within 30 minutes to 7 days. And the headache must have at least two of the following characteristics. It must be bilateral, must have a pressing or tightening quality, must be mild or moderate in intensity, and not aggravated by routine activity. And there's a nausea or vomiting is not there, but the patient might complain of anorexia, and there's no photophobia or phonophobia. And you must make sure there are no other attributed disorders before you make a diagnosis of tension type headache. Now, once you've diagnosed, how would you want to treat? So the treatment could be acute or preventive. Acute treatments, general over-the-counter medications like paracetamol and NSAIDs. You have to rule out any issue of peptic ulcer before giving NSAIDs. It's also been said that aspirin or plus caffeine can be used as a second-line treatment, just in case your primary pain relief isn't working. But with tension type headache, there's usually a risk of rebound headache. So you try to limit your treatment from 2 to 3 days, or to 2 to 3 days rather. And the preventive treatment could be pharmacologic or non-pharmacologic. For the pharmacologic, they say you could give tricyclic antidepressants, can give serotonin, select serotonin reuptake inhibitors. For the non-pharmacologic, you advise on proper sleep, also stress management. People advise yoga and all that, acupuncture and then physical therapy. The second type of primary headache I would like to talk about is cluster headache. Now, cluster headache, it usually occurs within a short time span, but it will occur periodically and affects males this time more than females. And it's usually common within the third and the fourth decade of life. For the cluster headache, it could be episodic clusters or chronic clusters. Now, for cluster headache, the definition of episodic and cluster is a bit different from the others. For the episodic, usually it will last from 7 days to 1 year. Remember, I said it lasts for has a very short time span, and then it reoccurs. So it can last for 7 days to a year, and then in between this time, the patient must have pain-free remissions at least for a month. For the chronic cluster, it usually lasts more than 1 year without remissions, or remissions lasting less than 1 month. Usually the onset of headache is abrupt. The specific thing about the cluster headache is it starts around the eyes. So it originates from the eyes and spreads over the temporal area. So the patients come and tell you that having severe headache, but realize it starts just around the eye region and it spreads to the temporal area. The pain is extremely severe and can last 15 minutes to 3 hours, but usually lasts between 45 to 90 minutes if it's not, if no intervention is sought. And headache is usually non-pulsatile. It's usually unilateral and associated with rhinorrhea, nasal congestion, lacrimation, and conjunctival erythema. The patient might present very restless or agitated during the episode of headache. And this headache is usually triggered by alcohol, which is the most common trigger, sometimes exercise, and it can also be triggered by medications like glyceride, trinitrates. How would you diagnose a patient of having a cluster headache? Like I said, it's usually unilateral, starts around the eyes and spreads to the temporal region. The headache is usually accompanied by at least one of the following. So either lacrimation on the lateral eye, so the same eye, or nasal congestion around the same part of the face, eyelid edema, or a sense of restlessness and agitation. The attacks have a frequency from 1 every other day to 8 per day. And you must make sure there are no other disorders that can be attributed to the headache. So this is usually how it starts. It's unilateral, so all the symptoms are affected or just one part of the face, whether the right or the left. So again, management could be in the acute phase or preventive. And for the acute management, usually you want to give patients 100% oxygen via face mask. So the triptans have been shown to have very good efficacy against cluster type headaches, and then the ergots also. For preventive management, it could be short-term or long-term. So short-term, if a patient if you made the diagnosis of cluster headache and say you've treated and the headache has subsided, place the patient on some steroids like prednisolone, also place the patient on ergots as a short-term management. And for long-term, medications like verapamil, lithium, and sodium valproate have been shown to have very good efficacy. Now we'll talk about migraine headache, which is also very common. We have a lot of patients who come with headache, and the first thing they will tell you is that they have a migraine. Now, the thing with migraine headache is usually episodic, and it's usually associated with nausea and or vomiting, and photophobia and or phonophobia. It may be preceded by focal neurological symptoms, and sometimes it may also, which the aura may not also be followed by a headache. It's commoner in women, and the mean age of onset is about 19 years, and its peak prevalence is from the 3rd to the 5th decade. Usually there is some genetic preponderance, so about 46% of patients with migraine will tell you they have a family history of migraine, and it's the risk is increased when both parents have a history of migraine. And about 30% may have other coexisting headaches such as tension headache. And remember, I said with the tension headache, it can be a rebound headache if you give analgesia for a long period of time. So the migraine can be classified into so many subgroups, but I just put a bit of them there. So migraine without aura, migraine with an aura, ophthalmoplegic migraine, retinal migraine, childhood periodic migraine, and then migrainous disorders that don't fulfill the other criteria. So the pathophysiology is not completely understood, and there are different theories. There's a vascular theory which says there's distension and the versatility of the extracranial vessels, which leads to a migraine attack. There's also the neurovascular theory, which says that migraine is primarily a neurogenic process with secondary changes in cerebral perfusion. And there's also the brainstem neuronal hyper-excitability postulates, and there's the cortical depression postulates with aura. But the one that is actually quite acceptable now is abnormalities with these hormones, so serotonin, CGRP, norepinephrine, GABA, dopamine, glutamate, nitric oxide, and endorphins. What has been known is that usually with migraine episodes, there's some form of vasodilation, which worsens the headache. So most of the medications that are given to try and constrict the cerebral vessels, which has been seen to reduce the severity of the headache. So just go forward a bit. So the clinical features in headache, it's usually unilateral in about 2/3 of patients and bilateral in 1/3 of patients. Usually the pain will be felt behind or along the inner angle of the eyes and also the frontotemporal regions. The pain sometimes radiates to the back of the occiput and also to the neck. Some patients who may complain of limb pain at the same side of the headache. Usually at onset, it's dull, and then later becomes throbbing, and then with each throb, the severity of the headache increases. The headache can also be described as being constant and one that worsens with movement. And it could be associated with aura. So the aura could be visual, could be sensory, and other type of auras. For the visual auras, present with some form of hallucination, flashing lights, and then the patient can tell you that they see these zigzag movements across the visual fields. Sensory auras also present some form of paresthesia, which spreads over minutes to hours. And they have other auras like dysphasia. Some patients can present hemiparesis, and then some distortion of the body part like tongue swelling. Now, what are some of the triggers? They say stress and relaxation after stress. There are some patients who have had a very stressful day, and as at the time they probably get home and try to rest, they start feeling the headache. Sometimes it could be due to sleep, either lack of sleep or excessive sleep. Also some it could also be due to hypoglycemia, some drugs. Like we spoke about the vasodilation that has been seen to be associated with migraine episodes, and also pregnancy, menstruation, and menopause. So I've just also tried to give chocolate also some diet. I also tried to give a diagrammatic representation of some of the triggers: anxiety, depression, even excitement itself, chocolate, cheese, alcohol, climate change, smoking, hunger, and sleep. So usually what will happen during a headache? So this is a patient, a normal patient, normal appetite. So there's a prodrome period, the oral period, when the headache is quite severe, its resolution, and the recovery period. So during the prodrome period, the patient might have increased craving, might feel quite tired, might have a heightened perception of noise, smell, and then before the oral is usually very short. So the most important time in managing the patient with migraine, because it said that it's better to prevent the migraine itself than to treat it. So the best time to manage a patient with migraine is during the prodrome period, because once the headache starts, sometimes it can be quite difficult to manage because the headache can be very severe. And the prodrome period lasts 2 to 12 hours. So we would really have to educate our patients whenever we see them and the things they should look out for if they are known to have migraine, so that they can start the treatment just around that period. So what are the differential diagnoses for a patient with migraine? Think of a TIA, because I said you can have hemiparesis also. You can think of a stroke, temporal arthritis, you can have also meningoencephalitis. Now, the diagnostic criteria for migraine, the headache lasting 4 to 72 hours, and the headache must have at least 2 of the following characteristics: unilateral location, and pulsating quality, moderate or severe pain intensity, and aggravation by routine or physical activity. And during the headache, at least one of the following must be present: either nausea and or vomiting, or photophobia and or phonophobia. Usually, the diagnosis for migraine is mainly clinical. So imaging modalities are not necessarily indicated, or are not usually indicated. And most times, you might not really say, it's said that about less than 0.5% of patients, imaging studies will detect some form of abnormality, but most patients don't have any necessarily abnormalities. But you have a patient that has a migraine, or you think has a migraine, in some circumstances, you would want to do some form of neuroimaging. So if the patient presents with the first or worst severe headache, or thinking of a subarachnoid hemorrhage, so you might not just want to rely on your diagnosis of a migraine. And the patient says there's a change in the pattern of previous migraine, or you examine and you realize that the urologic examination is quite abnormal, or a patient presenting with migraine type headache after the age of 50. Or you have a patient who is immunocompromised that presents with a new onset headache. So in these different situations, you would want to do some form of neuroimaging to rule out any other thing and not just stick with the migraine headache. Also, like I said about the subarachnoid hemorrhage, you might want to do a lumbar puncture if you're thinking of that, or if you're thinking of a meningitis, but then you would have to do a neuroimaging first before you do any LP to rule out a mass lesion or increase in intracranial pressure. How do you treat? Treatments could be pharmacological, non-pharmacological, and the pharmacological could be the acute setting or preventive. And I've said, usually treatment of migraine, preventive is usually the best form of treatment because you wouldn't want the patient to have the attack first. And for non-pharmacological, you have cognitive and relaxation therapy, and use vagus nerve stimulators. If the patient smokes, you can advise the patient to stop smoking, and then some form of exercise. Although it's also been said that exercise can trigger the headache. For the acute treatment, you can use simple analgesia with antiemetics, so over-the-counter medications like paracetamol, NSAIDs, or aspirin. The triptans have also been seen to have very good effect against the migraine headache. They actually help to cause some vasoconstriction. For the preventive treatment, you can use beta blockers, also use calcium channel blockers like verapamil, have a tricyclic antidepressants, you have anti-epileptic drugs, and some postulates have said use of botulinum toxin, which I've never seen before. But again, in terms of treatments, like I said, the goal is to prevent the attack itself before the patient presents with a severe headache. So you have to tell the patient about the prodrome period. So if they realize they feel tired easily and their appetite for food just starts increasing out of the blue and they are known to have headache, and I ask them to take some of the medication, especially the tricyclic antidepressant. That helps a lot in the preventive stage, because once it gets to the headache stage itself, sometimes it's quite difficult to manage. You have to give very high doses and very potent pain relief. I'll just stop here. So thank you very much for this presentation. Now I would like Dr. Gerald, who is our moderator.
Hope you can hear me.
Yes, sir.
The topic is actually very wide, so to deal with headache in 1 hour is a little too short. However, I'll make a few comments. First of all, on the definition that headache means pain in any pain-sensitive structure in the head and neck. Secondly, that headache can be a disease or a symptom that's clearly defined. It's a disease when it's a primary headache and a symptom when it's a secondary headache. So a primary headache has no investigatory input in terms of cranial CT scan, laboratory investigations are all normal. So in that case, it's a disease. Whereas if there are findings like a tumor or fever or any other thing, it becomes a symptom. The third comment I want to make is that the commonest headache is actually tension type headache. And the migraine ones, however, are the ones that will come to your clinic. So if you see 10 people sitting on a corridor waiting for headache clinic, 9 or 8 of them will be migraine, whereas 2 will be tension type. And the reason is that tension type is a dull headache that doesn't trouble you much. But after a while, you say, let me seek medical advice. The other thing is about prevention in migraine, which you rightly discussed. But I use Botox, so Botox is common. I use Botox for patients, and I give Botox for patients for preventive purposes. Just that it's a little expensive, and the coverage is only for 3 to 4 months. So again, the coverage is low, and it's about 190,000 for 3 to 4 months coverage to prevent headaches. But for those who have very, very bad headaches, then you need to give them that. The second thing about prevention is that by prevention, headaches have to be at least 8 times in a month to discuss prevention, especially migraines. The second is, or the headache is debilitating for more than 1 week, then we bring in prevention measures. And prevention measures means taking pills every day to prevent a headache that will come someday. And sometimes in the midst of prevention, you can have a breakthrough. My final comment is on what you call the red flags, which I've already highlighted, but just for emphasis sake, that if you have a headache that is not changing side, a headache that is has some neurological deficits, a headache that is greater than 50 years of age, a headache that has changed its pattern, probably maybe has migraine and there's a changing pattern in the headache, then you may need to image such a patient. However, overall, all patients that have headache should be imaged. But because of costs, these criteria were put together to help economically or low economic countries to be able to manage headaches better. Otherwise, all headache patients should be imaged as much as possible. For primary headaches, we need very minimal investigation. Aside cranial CT scan, we don't usually want to do much of investigations for them. But the CT scan or MRI is the investigation of choice. And after that, we don't want to do much because they're primary headaches and we don't expect much by definition. They have their criteria for classifying them. And there are many other types of headache. I just want to say that headaches are like 150 types, but this presentation is too short for such elaborate discussion on headache, but there are like 150 subtypes of headache, but we've delved properly into the primary headaches, and I think he has done a good job. So thank you all. We'll wait for any questions. If there are any questions for us to answer, we'll be glad to do so.
Okay, good morning, sir. Thank you very much again for moderating, and thank you for your input. There's a question from the house based on medication overuse headache. And the question is, what is it exactly? And then second one is it relatively common, or is it a relatively common occurrence in the management of migraine, of analgesic overuse headache?
Okay, so the overuse headache is not even peculiar to migraine, it's peculiar to all headache types. So analgesic overuse headaches are headaches that are classified as those induced by analgesia. So patients usually will take some form of pain relief every day. And so the days they don't take the analgesics, they develop a headache. That's one class of analgesic overuse headache. The second class of analgesic overuse headaches are primary headache disorders who are not getting appropriate treatment. So what do? They take a lot of paracetamol. And of course, I don't know whether you did mention that we don't normally use paracetamol primarily for treatment of headaches. The reason is that headaches are inflammatory, by definition for what you said about pathophysiology. So you need an anti-inflammatory agent. So the first thing we do when we get this kind of analgesic overuse headache is to stop all painkillers and put them on non-steroidal anti-inflammatory drug and prophylactic headache drugs. So these are the two things we do. So we must do prevention, and it's very common in terms of common use, because most people who have headaches go over the counter, but the most common overuse analgesic is paracetamol or acetaminophen. That's what we usually have access to. So that's why it's usually common. They also have those categories, like the first category I said are like truck drivers and so on. Those people just take paracetamol to keep themselves strong when they're traveling. They can take paracetamol and then end sick. So they don't take it, they can develop a headache.
Okay, sir.
More questions?
Okay, sir. Thank you. Another question from the house is, why is oxygen used for the management of cluster headache?
Well, studies have shown that, in fact, that is the best treatment for cluster headaches. Unfortunately enough for us, it's not so common. Clusters are not so common. It's commoner in male population than in female population, of course. It's not so common in my practice. I probably have had only like 10 cluster headaches. We probably only one female. The rest are the males. You know, so oxygen is the drug of choice. We are not sure why it's like that, but that is what has been found to be useful. And oxygen at least 8 to 10 liters. 8 to 10 liters of oxygen is what we need. High oxygen flow, and you give it for like 10 to 15 minutes. The patients are good. And in fact, you can use that even as a diagnostic criteria, because once you do that, the headaches go automatically. You know, some of them even buy their oxygen tank because they want to administer it on their own. Luckily for us, clusters are like the name implies, that clusters. So they occur in clusters, so they can stay after this year. They may not occur until next year by this time again. So it's not a difficult thing to manage as such.
Okay, sir. There are two more questions. One is, how do we abort migraine headache in a pregnant woman in her third trimester, seeing as NSAIDs and triptans are contraindicated?
Yeah, that's a very difficult one. But by and large, what we tend to do is to use paracetamol and steroids. That's what we use basically in third trimester. Unfortunately, but luckily for us, I want to say that headaches, because of estrogen progesterone gene, is one of the diseases that is protected by headache. One of the diseases that headaches are not common with. So if a migraine gets pregnant, headaches are going to be less. So migraine, epilepsy, and some other diseases reduce with pregnancy, and whereas some other autoimmune diseases worsen with pregnancy. So luckily for us, migraine is one of those diseases. However, if we have that happening, we use steroids and paracetamol. That's what I will use for these patients.
And the last question is, what of the use of Panadol Extra? What is your...
Yes, I feel in some as we improve their headache, there's no argument about that. But like I already said, headaches are inflammatory. So if you do caffeine, you are doing analgesia. It means that the inflammatory cells which have been called to work are still there, releasing their cytokines and causing more pain. So what you are doing is analgesia. Of course, some people will be relieved. There's no argument about that. Some people may worsen, but some people will be relieved. But the same thing goes with a gut, coffee gut, and the rest of them. They are just doing analgesia. Analgesia is not your endpoint in headache. Your endpoint in headache is anti-inflammatory. So that is the take-home message. It's anti-inflammatory. That's the endpoint. So you must use an anti-inflammatory drug as much as possible. Sometimes patients have ulcers. So what do? We give them omeprazole or rabeprazole, as the case may be, to protect their gut. Cerebrate is a little too slow. Its onset action is too slow, and by definition, if a headache has not gone after 2 hours, then that agent is not good enough. So you will need a better agent. So our drug of preference is actually naproxen, which starts working on like 15 minutes, or otherwise we get the catarrh found fast. That will also be beneficial.
Okay, thank you very much, sir. We appreciate you for moderating and answering our questions. This will be the end of the presentation.
Thank you very much.
Thank you, sir. Thank you.